in Baltimore County, I'd like to welcome you to our 9th annual Judith A. Shinogle Award Lecture. The award was established by the family of Dr. Shinogle to recognize a student whose research exemplifies the scholarly rigor and the health policy focus of Judy's work. Judy was a former senior research scientist with the Maryland Institute for the Policy Analysis and Research, and she was also an adjunct associate professor in the School of Public Policy until her untimely death in May of 2012. Judy's work for MIPAR included studies on childhood obesity, wellness initiatives, and gambling. And this afternoon, we're pleased to have Judy's sister, Dr. Mary L. Cohen, and one of Judy's friends and colleagues join us to share their memories of Judy prior to hearing the award lecture by this year's award recipient, Ms. Zippora Kiptanui. So first, let me begin by introducing you to Judy's sister, Dr. Mary L. Cohen. Mary L. Cohen is Judy's Shinogle's younger sister, and she is an associate professor of music education at the University of Iowa. She researches music making and well-being, songwriting, and collaborative communities. Along with co-author Stuart Paul Duncan, they are completing Music Making in U.S. Prisons, Listening to Incarcerated Voices and this is under contract with Wilfrid Lawyer University Press. She's collaborating on international initiatives to explore research on music making in prisons and peace building, including an upcoming keynote for a research seminar for the social impact of making music. Dr. Cohen's research is published in International Journal of Research in Choral Singing, the Journal of Research in Music Education, the Australian Journal of Music Education, the Journal of Historical Research in Music Education, Journal of Correctional Education, the International Journal of Community Music, the Prison Service Journal, International Journal of Music Education, and in numerous book chapters. So again, please join me in welcoming Dr. Mary Cohen to hear her reflections on her sister Judy.
Thank you, Dr. Miller. It is such an honor to be here, and it's so powerful to watch that video of Judy and those images. The song we heard was by a former graduate student, Dr. Catherine Wilson, and I'll never forget when I was in Wichita helping to prepare for the funeral. I woke up one morning and Kat had sent me that song, and it's just so powerful to hear it. So we're here today to celebrate Judy and to honor her and to honor our winner this year, Zippora, which is so exciting that she has a pharmacy research interest, because I'll be introducing when I'm done April Shaughnessy, a good friend of Judy's, who also researches in the pharmacy area. And while I'm speaking on memories of right after Judy died, I just know this little candle that I received from April. I remember sitting in my office. The University of Iowa, there was a huge flood in the summer of 2008. So we were displaced from the music building that we were in. I was in another building, and I get a package at my university. I open it up, and the candle says, there are some who bring a so great to the world that even after they're gone, the light remains. And Judy was definitely a light for me in my life. She influenced me to do 3 things that I love tremendously. She influenced me to teach group fitness, because she was very much into fitness, all sorts of group fitness. In fact, when we cleaned up her home after she died, I was so surprised to see as many fitness gadgets as she had in her home. So also, she influenced me with music. I wanted to take piano lessons because Judy took piano lessons, and I thought it was really cool how she did that. And then when she earned her PhD at the University of Johns Hopkins, and Matt, my husband, and I got to attend her PhD ceremony, I was just so inspired by her, and that influenced me to also earn my PhD. So on behalf of my family, I want to just wish a lot of gratitude to everybody at the University of Maryland MIPAR Center, Dr. Miller. Thank you very much, Miriam, for all the work you've done to coordinate this event today. And, I just wanted to honor Judy today in kind of a special, just in a small way. Judy, you may know that the week after Judy died, her friends had a celebration of Judy's life, and they gave these orange bracelets away that said, "What would Judy, WW Judy D, what would Judy do?" And the answer was find the joy. Judy was always a person that knew how to work hard and knew how to celebrate hard and just connect with people. So, two parts to this story, and then I'll introduce April, who will speak next. One is in my own process of grieving, what does it mean? How do you find joy when you're dealing with grief? I wrote a song titled Find the Joy that the choir that I led before the pandemic, the Oakdale Prison Choir, sang. And the lyrics, I wrote the lyrics and the music. The song is called, it was about how do you find joy when brick walls block your path? How do you find joy when you're living through the aftermath? And in that song, we worked on it, and then walking out of the prison one day, the choir is made up of people from the outside of the prison that come and sing with men who are incarcerated. And Kevin Coomer, one of the outside volunteers, said, "Mary, you know what? I like that song you wrote in honor of your sister." And he said, for him, we actually don't have to go out to find the joy, because the chorus was, how do we find the joy? He said, "Mary, it's always within us. It's just a matter of pausing and noticing and feeling it." And I think that message really resonates now as we are dealing with the aftermath of the pandemic and the different stresses happening in the world, that if we can use our own well-being to feel that joy that's always within us, we will be able to function in so many more effective ways. So I did a small thing today in honor of Judy. I don't normally step out of my office to go get a coffee, but I finished a meeting that ended a little earlier than I thought it would. And so I'm like, I'm going to go across the street in the University of Iowa City. Across from the music building is this little coffee shop called the Encounter Cafe. And I hadn't even been inside it since the pandemic. So I went in, and they're really well known for their cinnamon rolls. And you might have seen an image of Judy with my mom and my mom's mom. And my mom's mom, Grandma Bonaman, made the most amazing cinnamon rolls. So they had a cinnamon roll latte, and I had one of those in honor of Judy today. So I'm going to turn it over to April, who's going to share a little bit more. Thank you, April.
Thanks, Mary. Okay, so I swore I was not going to get choked up and teary, but watching the pictures, they did bring me joy and they made me smile, but they also made me a little teary. So I'm going to try to get through this without choking up too much, but I'm very honored to be here to share some couple of fun stories, ones that you can tell in public, about Judy and my escapades through our friendship and early life at APHA. Judy and I met when she came to the American Pharmacists Association to be an executive resident in association management. I had just completed the same program and stayed on at APHA. And so we really built our friendship from that. And she too stayed on at APHA after her residency for a few years until she left to go up to Harvard in Boston. But we stayed friends, even though it was a little bit harder. That was pre social media and Facebook and the ease of connecting, but we remained good friends. And when she moved back to DC, we sort of just picked up right where we left off. So you heard about her professional accolades from the introduction, but you might not know some things about her personal life. So through some of the pictures, you saw that Judy really loves sports, taking part in them and being a fan. And she was a volleyball player. Did you all know that she was a volleyball player? Well, she loved to play sand volleyball at these sand volleyball courts at a park not too far from APHA, right on the Potomac River. We all thought she was nuts, but she loved it. And she was there lots of weekends and tournaments. She raised and trained German short-haired pointers. You saw a picture of Bruni in agility, and they were national champions, and it was really fun. She had a whole world of friends through her work with her dogs and training them for agility. Judy was a big fan, excuse me, of the Washington Capitals. You might have seen a picture. She's decked out head to toe in Washington Capital gear. And she also loved the Washington Nationals. And her favorite player back then was Ian Desmond. We share a big part of our life spans with the Nationals, and although my favorite player was Tyler Moore, who's no longer with the Nats, and then it was Max Scherzer, and he's no longer with the Nats, so I don't really have a favorite player now, but I still love them. While she was at, I think, the statistic organization, she met a friend, made friends there with a woman who became the kind of the leader of a season ticket group for the Nationals, and Judy joined that season ticket group. And after passing, her longtime boyfriend, Jim, took on the shares in the season ticket group. And I was lucky enough to share those tickets with him for a number of years. And then he dropped out, and I still remain as in Judy's spot on the seniority list as a member of that season ticket group. The seats are awesome. They're right up from the Nats dugout, just a few rows up from the Nats dugout. And whenever I go to a game, and I haven't been in 2 years, so I hope to get back this summer, I always get a Leinenkugel Summer Shandy. That was Judy's favorite beer to have at a Nats game. And we raise the beer. So today I'm going to raise a Diet Coke, also one of Judy's favorites. And it makes a little connection, makes me smile, and a little connection with Judy when I go to the games. So as Mary said, Judy's life motto was find the joy. And it has been really hard the last year and a half to find joy when we're kind of stuck in isolation or maybe not doing the things that bring us good joy. But over the last week or so, when I was thinking about this, I decided that it was time to find the joy. And so I stopped now a minute sometime during the day to think of something that I'm grateful for and try to find some joy of something that happened that day or something I was looking forward to bring a smile to my face, maybe ease the stress a little bit. And it makes me smile so I hope that you all can maybe take this little bit of Judy with you and stop each day and think about something fun or something that brings you great joy. And that's a small way to connect with Judy. Even if you didn't know her personally, it would be a way to connect with her memory. So I wish you all a very happy Thanksgiving, and hopefully you're able to celebrate with your family and friends. And congratulations to this year's recipient. I'm very excited to hear your presentation. And thanks again, Mary, for inviting me to share just a couple of stories about Judy. And it's been really fun thinking about what to share with all of you. And it does really bring a smile to my face. And I did it. I made it through. I think Judy helped without choking up too much. Thanks, Mary.
Beautiful. Thank you, April. I think I turn it back over to Dr. Miller now.
Thank you, Mary and April, for your sharing your memories of Judy with us and giving us some things to kind of think about in ways that we might kind of reflect and remember Judy ourselves. So now it's my pleasure to introduce Ms. Zippora Kiptanui, and she's this year's recipient of the Judith A. Shinogle Award. Zippora is a project manager at Index Analytics, which is a small business contractor working to support the Centers for Medicare and Medicaid Services. Zippora completed her training in pharmacy in Kenya in November of 2002, and having worked for 6 years in patient care and pharmaceutical marketing in Kenya, she then moved to Minneapolis, Minnesota in 2009 to pursue a master's in public health at the University of Minnesota, where she graduated in 2012. Later that year, Zippora moved to Baltimore to start a 2-year research fellowship at the University of Maryland School of Pharmacy. And she later enrolled at UMBC's PhD program in 2016. And actually, I think your first semester, Zippora, you had a class with me. You took our introductory policy analysis course with me. So I had an early introduction and a great chance to meet you. Since then, Zippora's work has focused on issues around access and use of prescription medications. And which I was surprised but happy to find out. Zippora and I kind of share at least one common thing that we do when we aren't like teaching and doing research and things. Zippora enjoys reading, buying yarn. I buy yarn. Zippora buys lots of yarn, and we both like to knit. So with that, Zippora, we're looking forward to hearing more about your dissertation work. Thank you.
Thank you, Dr. Miller. It was so nice to hear about Judy that I forgot that I was going to do a presentation. So yeah. Okay. I'm sharing my screen. Can you see my screen?
Yes.
All right, thank you. So I just want to start by saying thank you. I know thank yous are usually at the end of a presentation, but I couldn't help myself but just start by saying thank you to all those who have contributed to getting us here. And first, I thank Mary and April. Thank you for keeping Judy's memory alive, and the blessing that you give to us by sharing the memory of her life with us. And from today, I take your challenge to find joy, particularly in her memory, on a day like this, but to try and do that every day, to find joy every day. I also want to thank my family. I have family in Kenya, and I couldn't help but I saw two of my family members calling in from Kenya, my brother Peter and my cousin Valerie. I'm looking at the time zone and thinking, oh wow, I really appreciate that you're here. But I also have adopted family here. I saw Jim, I saw Kate, I saw Christine, I saw Susan. I appreciate you all. And thank you for all the motivation that you give me to keep going. And then last but not least, thank you to my dissertation committee, particularly Dr. Miller. I've been with her since I was a student, and then she became my advisor. Thank you for your intellect and more so for your patience. Even when I changed my proposal topic twice in a year, you still stayed with me. So thank you for that. As Dr. Miller mentioned, I'm from Kenya, originally by way of Minnesota. And during my fellowship at the University of Maryland, I really got interested in the issue of prescription drugs. How the prescription drug market works, and even issues around access, and why do we pay so much for prescription drugs in this country? And this has been a running theme of a lot of my of the work that I do. And so one of the drivers of why we pay so much for prescription drugs is novel drugs. And these novel drugs are primarily, I would say, the result of advancements in research, particularly research around the human genome, where researchers are identifying many genetic variations that underlie both rare and uncommon conditions. And because of these research advancements, we are discovering a lot of genes, proteins and pathways that have become powerful targets for new drugs. And these new drugs are specific to specific populations or individuals carrying or expressing a certain gene. So these novel drugs often are innovative products, and they end up meeting unmet medical conditions or significantly help to advance patient treatments. And a lot of these the active ingredients of these novel drugs have never been seen before, or have never been approved before in the market. And you will hear the term biologics, mostly because they're based on biologic materials such as genes or cell content. And these novel drugs have three characteristics that I really want to explore, or that that are relevant to my research. First, because these novel drugs, by definition, are new, and they're sometimes the first of their kind. There's a greater role for learning by physicians and patients, and we have less experience with them, and so it takes time to get familiar with all the risks. Second, the FDA has used one or more of the expedited pathways that I've listed here to approve these drugs, and because some of these drugs actually are approved by what you call a surrogate endpoint, as opposed to the actual benefit, as opposed to the actual clinical benefit. So a surrogate endpoint could be something like a tumor shrinking, right, as a marker for overall survival when looking at cancer drugs. And the third aspect of prescription drugs that is relevant for me here is that these medications come to the market at a very high cost, either for each course of treatment, or when you look at the aggregated costs of care, for example. And these costs are really of particular concerns for public programs such as Medicare and Medicaid that have. And so I just want to show you some examples. So when we have this debate about novel drugs, it's usually a two-sided discussion, right? There is one side where we are thinking about the urgent need for these medications because they address unmet medical conditions, or it's there's a treatment gap. We have something that doesn't really work well, and then the other side, which I have mentioned a little bit, is that that there is the cost concern. And so here I'm showing an example of a drug called Zolgensma. And this is a medication that was recently approved for treatment of spinal muscular atrophy, which is a rare condition caused by a defective gene. And this disorder actually destroys the nerve that controls muscle. And if left untreated, infants actually with the more severe form of this disease typically do not live beyond their second birthday. And how this drug works, just a little bit about it, is that it works by replacing the missing function of the gene. So, here on the screenshot I just took from the manufacturer's website is a little boy called Eli who has lived to his 5th birthday because of this novel drug. And we can assume that if it wasn't for this drug, maybe he would not be here. The other side of this debate, or the other side of this drug, is, however, is that the drug comes at a $2 million price tag, $2 million price tag. And so when it came out in 2019, it was actually labeled as the most expensive drug ever. And this is a drug that a patient, a child, would have to take for the rest of their life. And so if you are a program director for like a Medicaid program, you have concerns if you just have 1 or 2 patients that you have to, provide this drug to. But then on the other side, if it's your child, what is $2 million for your child? So that's a two-sided debate. The other drug I want to highlight is Aduhelm. If you've been listening to the news, you must have heard of this drug. This is the first treatment approved in almost 20 years for the management of Alzheimer's disease. And as you may know, Alzheimer's disease is the 6th leading cause of death in America. And it's an irreversible progression of a brain disorder that destroys the memory and thinking and skills and eventually leads to death. The drug itself, it's a biologic agent, and it acts by slowing down the progression of the cognitive impairment that comes with Alzheimer's disease. So it really doesn't cure Alzheimer's, but rather it alleviates the symptoms. And this drug itself comes with the possible risky side effects of swelling of the brain and bleeding in the brain. And there is still ongoing debate really about whether what is the strength of evidence for this drug. I'll not go into it, but it's an ongoing debate. And even beyond that, this drug, even though it has been approved by the FDA, it comes with a price tag of $56,000 per patient. And so, not many patients will be able to take it. And then when you think about it, there are about 6 million people in this country living with Alzheimer's disease. 90% of them are over the age of 65. And so that means potentially that the program like Medicare would be covering and paying for this drug. And so I have just put a news clip out there from Massachusetts General Hospital that highlights that many physicians and many health systems and not have decided to not prescribe this drug because they want to wait for information about the actual benefits and whether it is even cost effective to provide this drug to patients. And so finally I get to my dissertation topic. And so this is where I thought that what I'm interested in looking at is given all this uncertainty about the drug, about novel medications, how do healthcare providers, payers, even states confront issues around the value of the drug, the risk of the drug, and the cost of the medication? How do you balance all this to make a decision about using this drug? And so I titled my dissertation, Examining the Evidence for Novel Drug Approval, Coverage, and Cost Policies. And so for my dissertation, I want to explore the evidence used in making these decisions in two parts. One, outside of clinical trials, I want to look at what is the evidence with these novel drugs. What is the real world evidence is what I use typically. What is the real world evidence of using these drugs? And then to many of these drugs, like I said, come to the market with a really high cost. So how do states, governments that have limited budgets use evidence to come up with some sort of cost containment strategy for their population? So the first part, I did a systematic literature review where I identified the real world evidence for using these drugs. And I had three research questions that I've listed here. One is looking at the outcomes that are outcomes from using these drugs that are in the real world, meaning outside of the clinical trials. Two, I want to look at the characteristics of patients who use them in the real world setting. And three, how do insurers and payers balance the limited information that they have about the drug and the cost in terms of thinking about how to cover the drug. And I used two databases to do my literature review. I have listed them up there. I used search terms corresponding to 3 keywords, mainly to identify the drugs that were approved through these FDA expedited programs, and then also keywords that looked at the impact of those drugs, and then cost outcomes relevant to those drugs. I'll not go through this, but this was my inclusion criteria for the studies that I found. And I wouldn't spend too much time here as well. But after applying the inclusion criteria, I had 16 articles that met all my inclusion criteria. And for each of the 16 articles, I grouped them by 4 main outcomes. One was patient experience, healthcare utilization cost, and payer experience. And I will just quickly highlight interesting findings. And one of those was that patient outcomes in the real world can be better, similar, or worse than in clinical trials. And access to these novel medications varies by the type of insurance you have. So those who do not have insurance have to wait a little longer than those who have Medicare coverage or have commercial insurance. On cost, here no real surprise that these drugs really came at a high cost. However, some studies suggested that the high cost can be offset by the additional benefit the additional benefit that comes with lower medical costs for those patients who actually take the full cost. And then for payers, I thought it was interesting that Medicare seems to cover these novel drugs at a higher rate. Some of these novel at a higher rate versus others. And then payers have come up with a lot of cost containment strategies, including just limiting the cover, ensuring that there's some sort of a tier assignment so that you pay more when you're in a certain tier versus another, and then cost sharing, meaning the patient gets to pay much more for some drugs, and then also additional limitations such as ensuring that a patient uses a drug X before getting to a drug Y, which then leads to managing the use of the drug. And then in conclusion, from my literature review, I think while I did not have many studies in my literature review, I thought that the findings could be beneficial for two reasons. One, these studies really do give us insights into drugs for rare diseases or unmet medical conditions that may not have other therapies. So we get some information that we would not have had if these drugs were not used. And then two, because the evidence on the health outcomes from using this drug is still evolving, I think this opens up an opportunity for negotiations between the drug manufacturer or even the FDA and other payers. For example, the FDA does require that some of these drugs that are novel have additional research even after the drug is approved and is on the market. Or it also opens doors to establish contracts between manufacturer and the payer, where the payment for the drug is dependent on achieving certain clinical outcomes from the drug. And that will be the focus of next paper. So that led me to my second paper, the second part of my dissertation, where I want to focus on state-based programs. And just a little bit of a background, states are a significant purchaser of healthcare, including prescription drugs, because they provide healthcare coverage for many populations, including those under the Medicaid program, inmates in correction facilities, or even public workers, such as teachers, or even universities, public universities. And then two, states must balance their budgets annually. That's a given. So they have a limited budget, and you still also have to balance your budget annually. And then another of importance, I want to focus on the Medicaid program for my dissertation. And for the Medicaid program, this is the nation's largest public health program, and it provides health insurance for low-income individuals, low-income families, and those who have disabilities. Each state in this country has a Medicaid program, and about 1 in 5 Americans is covered by the Medicaid program. And then prescription drugs are included as one of the benefits of the Medicaid program. And then specific to Medicaid and novel drugs, specific to Medicaid and novel prescriptions, a lot of state Medicaid programs have expressed concerns that these, concerns about paying for these drugs, these novel drugs that are approved by FDA's expedited pathway. And this is particularly because, the high list price that they come onto the market, and, you're paying for a drug that has a high list price, but you really are not the evidence around the clinical benefit is still yet to be confirmed. And states have tried to do a few things, to try and address this cost concerns, and they have implemented new payment arrangements called value-based purchasing strategies, which tie the drug to some measures of patient care, which I'll talk about this in a. And then just a little bit, just to highlight how important or how critical this issue around novel drugs is to Medicaid. Here I'm showing biologic drugs as a share of the number of prescriptions that are sold, and as well, and the spending of these drugs by the Medicaid program between 2019. And biologics, I may have mentioned earlier, are an example of novel drugs. And in this chart, it just shows that while these biologic medications account for a very small share of prescription drugs that are prescribed, between just about 1% of the prescription drugs that are prescribed, they make up a disproportionate share of the Medicaid spending. So between 15 and 21%. And given that many of the new drugs that are coming on the market will be novel in nature, so there'll be novel drugs, we expect that this trend will only continue. They'll account for an even larger share of spending on prescription drugs. So for the second part of my dissertation, I want to explore this concept of value of prescription drugs. Particularly, are there alternative ways for us to capture the value of a drug rather than just using the measures that we have right now? I also want to explore characteristics of these value-based arrangements that Medicaid programs are using to address this high cost. And I also want to look at some challenges, how for those that are implementing these programs, how do they how do they overcome the challenges that they face them when implementing the program? So part 2 of my dissertation has 2 activities. First is an environmental scan to identify the frameworks that are being used, these alternative frameworks that are used to define the value of medications, and then collect some information on these value-based models that states are implementing. And then third, I'm going to do some interviews, some key informant interviews with state Medicaid representatives to talk about, successful strategies and how they overcome some of the barriers in implementing these models. So I'm still working on part 2 of my dissertation, but I can share some initial findings here. So one is that our current reimbursement methodology, how we pay for the drugs right now, is what you call a cost plus. And so here the drug manufacturer really, sets the price when they launch the drug, and then they negotiate the actual. And so this drug is just based on the cost of manufacturing the drug plus the manufacturer's profit. On the other hand, the value-based pricing approach requires that the price of an item, a commodity, should reflect the value that the buyer is getting rather than the actual cost of production of that drug. So when you think about it for a novel drug, value can be defined as the additional benefit that this particular medication or this intervention is offering compared to whatever would have been the standard of care. And from my environmental scan, I have identified 5 value frameworks that are being used to determine the price of prescription drugs. I will not go through each of them, but I just want to show here, how I have grouped them by the group that they represent, who developed them, the target drugs that are used that are used in the framework, and then the audience or the intended user for that value framework. And my next step would be to take those value frameworks and compare them across 4 concepts. So to the left of the screen is, identifying what is the alternative domain by which the value of the drug is being assessed. So, for example, does the framework consider the unmet need that the drug is treating, or does it consider overall survival, or improvements of quality of care, or the impact on dignity? And then 2 is to compare it across, I want to identify the method that's being used to measure that particular domain. So how you measure survival, how you measure unmet need. And then 3, how those domains are aggregated, the different components of value, how they're aggregated to finally establish a value that's in a dollar amount, how you convert that value into a dollar amount that becomes the price. So like I said, the work there is still ongoing, but I hope to be done by December. And then the final part of my dissertation is to focus on Medicaid programs, where I want to look at those innovative payments that are being implemented in my states to address these novel drugs. And like I said earlier, I plan to look at those, to do key informant interviews to identify those strategies by state Medicaid programs. And I mentioned earlier that states have gotten into these value-based agreements or contracts with drug manufacturers for their Medicaid program. Sometimes you'll hear the term alternative payment models. And these contracts tie payments for drugs to a metric of volume or patient care. From what I have found, first off, I think I should say that this concept of making payments and tying a payment to a certain outcome, it's not new. I think the Medicare program is already doing some of these as part of their hospital and physician reimbursement. However, value-based payments for prescription drugs is actually relatively new in this country. And what I have found is that there are 10 states that are implementing these programs for prescription drugs. And an example here that I'm showing is the what it's called the Netflix subscription model. And here, this model targets manufacturers of drugs that are used to treat or manage hepatitis C. And state Medicaid programs, how it works is that the state Medicaid program pays a flat fee, a flat subscription fee, so to speak, to the manufacturer, with the commitments that the state program will actually purchase a certain volume of the drug over a certain period of time. And this is in contrast with the traditional method where the state would be paying for each individual unit of a drug that a beneficiary is taking. And then once the state reaches or gets to that particular volume that is agreed upon, there is an agreement that the state will procure additional drugs at an even lower price. And from my findings, there are 2 states that are implementing this particular model. That's Louisiana and Washington for their hepatitis C drugs. So, like I said, I plan to do key informant interviews with state representatives from 5 states. At least 5. That's my target. I hope to get more, but I'm targeting 5. I have developed an interview guide which has 6 domains. So I have listed them here. So I want to talk about what were they hoping to achieve? What was their motivation in developing these payment arrangements. I want to look at the disease areas that are being covered. Are they, how do they go about developing these frameworks, and also looking at any outcomes that they are tracking or requiring that the manufacturer tracks, and then getting an aspect of some satisfaction or dissatisfaction with the current arrangements that they have, and even future models that they want to see in the future, in the coming years. It took a while to come up with this question, mostly because when I think about these contracts, it's a business agreement, and so there might be some proprietary information in there. So I'm hoping that my questionnaire or my questions are more general and not really specific into getting into the details of those agreements that they have. And so to date, I am working on my IRB, and I hope to get that done this month and be able to conduct my interviews early next year and be done with my dissertation, hopefully by May of 2022. That's what I had to share. And thank you for listening, and I welcome any questions that
Thank you so much, Zippora, for your presentation, discussion of your dissertation in terms of what you've completed so far and the work that you'd like to do. And so, Zippora said, we welcome any questions you have right now. You can enter questions into the chat or unmute and just ask your question, or comments. We welcome comments as well.
Just want to give you a big congratulations. I find that your interest of your research area aligns so much with what Judy has done. Judy has her undergraduate degree in pharmacy or PhD in health economics, and all of the things you're interested in with respect to the cost of drugs and all of this is just, it's fascinating. And I hope someone on the call with a stronger background in research with pharmacy will ask you a question, but the thing that immediately came to mind is we're watching the series Dope Sick, about OxyContin, and the question of these pharmacy companies that have just done what they've done. And I don't know to what extent any of your research, you look at some of that history and look at, so if you have anything to say regarding that, I welcome that. But if someone else does have a more specific question related to Zippora's research, please type it in the chat so we can get to your question.
Yeah, I think my only comment is I think that I haven't watched Dope. I've watched a little bit about, just some trailers about it, but I think it somewhat gets to the issue around how the health market in this country operates. It's one, even when you just if I just focus on prescription drugs, that there are so many intermediaries. So I think about it, that if you asked me, hey, drug X, how much does it cost? We really can't come up with a price. My question to you will be, do you have insurance? If you do have insurance, who's your insurer? And then now we get into the details. What type of plan do you have? Do you have a deductible? Do you have a copay? And then where are you in that deductible or copay? So it gets to how how we have structured healthcare in this country, and I guess there are pros and cons, to how the structure is, because if you want it and you can afford it, you'll get it. But it leaves a lot of people without the access, or without the ability to pay, because even for those who have insurance, just having insurance, that doesn't mean you can afford it. So there is a lot, I think, to unpack it in there.
And then a follow-up question. Thank you. Are there any effective models from other countries that we can learn from? Maybe even back in Kenya, Canada, other places?
Yeah. So yeah, I considered actually looking at the international, what other countries are doing, and it was going to be broad. One, I want to graduate, but it's there are a lot of good things we could borrow, but I think it's a double-edged sword, whichever way we go, and yeah, it comes back in my mind to how the market has just been set up. It's just so different how the markets operate. So yeah. There's a question here, and the question is there a way to look at the cost savings of using the drug versus the potential reduction cost of patient care with better patient outcomes? So is the question looking at are there better ways? Are there cost savings from using the drug versus not using the drug? I think they are, it depends on the drug as well. And I think there are ways that, there are studies that do look at that, and maybe if I get a bit more detail on the specific drug you're talking about, I might be able to answer that. But the general answer is yes, there are ways to look at those. There are measures or there are tricks that do that comparison. And then there's a question, has there been any discussion about developing a specific fund nationally? Okay, perhaps a fund by all companies, developing those agents with expected price tag in millions and perhaps a national board. Okay, so it's almost like, can you use public funds for research or having a common pool to do research and development? And that makes me think of the vaccines that hopefully we all have, that we've all just taken. I think a lot of those, like I know for sure Moderna was funded, received funding from the NIH. So that is a good success story of how public-private partnership can get a drug to the market.
So Zippora, I have a question. If we go back to the you had a slide that showed like the 5 or 6 different kind of models that were out there right now for thinking about value-based purchasing, and they focus primarily on novel drugs or medications related to either cardiovascular disease or cancer. Do you have a sense about why those are a particular focus right now, or at least kind of initial focus for these models?
Yeah, I think it's driven by the developer, right? So how I could pull up my slide, but if a lot of those models are developed by professional associations, particularly those in oncology, cancer care, or cardiology. So it's being driven by professional associations, and the goal is to be able to provide, and their target audience or their target market really is more around, it is the clinicians. So they're looking for a way to support their clinical care, as opposed to maybe patient, directed at patients to be able to evaluate those drugs or even pay. So they are primarily driven by professional associations who come together to be able to make sense, or even be able to order or to come up with a prioritization or clinical guidelines for how to use this medication. And then cost then becomes one of the factors that they consider. Model.
Great, thank you. And we had a question in the chat that's asked related to you're doing your key stakeholder interviews with state Medicaid programs, and whether you think that will generalize to the Medicare program or to private insurers or other payers.
Good question. Whether it's generalizable. I think it could be generalizable to other states because the Medicaid program is set up in such a way that all state Medicaid programs, for example, operate under the same policies, right? In as much as they're all state-based, there are certain, for example, benefits they must offer, or there are certain guidance or policies that they must follow. So, for example, the Medicaid drug rebate program is how, it is the policy that guides coverage of prescription drugs, outpatient prescription drugs for all states. And so, given that, because of such federal guidance, then it could be possible to implement some of those models or payment arrangements across multiple states. On the other hand, these are negotiations, right? And so it requires that each state initiate the negotiation with the specific manufacturer. And for that particular drug that's targeting a specific population, I don't know if there'd be differences within each state, so it just might be about, it might come down to the prevalence of the condition in the state. I don't know if there'd be variation by state. So I think there are aspects that definitely can be operationalized across all states, but it might also depend on the specific drug that's selected for alternative payment models. In terms of whether it's generalizable to other payers, maybe not, because again, the Medicaid program is a little different than the commercial payer, so it might be a different financial arrangement.
Thank you. I think, okay, we have another question in the chat, which is whether the pharmaceutical companies are transparent on how they price the drugs.
I think we can all say no. It's a box. Like I said, I am originally from Kenya, and I worked for a pharma company, and knowing that, you look at the same drug here versus the same drug in Kenya, the price is very different. It's the same drug, the same brand drug. So there is no transparency for sure. And a lot of it is said to be the cost of manufacture, but I think there is information out there that's been published that it also is dependent on the market. The pricing is relative to the cost of living, or the country itself, and so the metrics itself, beyond the cost of manufacture and the profits, there is a black box in there that we don't have transparency into, and that's why maybe using this alternative value-based frameworks could be a way to go, because you're just looking at the value of the drug. What is it giving me that I don't have? Is it addressing an unmet need? Is it extending survival? Is it giving me dignity? And then put a measure, put a value to those, put a price to each of those additional value. And reduce that pricing.
Great. Thank you. So I want to, first of all, thank you again for your presentation. And we're all looking forward to seeing you be hooded in May at our commencement ceremony. So I'd like to thank again everyone who attended this afternoon's lecture. I'd like to especially thank again the Shinogle family, Mary, for joining us and for your generosity in setting up this fellowship so that we can recognize people like Zippora and others like her who are doing research in this area. On our website, you can find out more information about the fellowship as well as prior recipients. I think we have recordings of almost all of the prior award lectures, so I'd encourage you to check that out if you're interested. And also just to note that while this fund was generously set up by Judy's family, there are possibilities or ways for you to also contribute funding to the fellowship. And so the program that Miriam shared with you in the chat gives that information, and you can also find information on our fellowship website. So thank you again, everyone. Support best as you move forward, and everyone have a good evening.
Thank you. Thank you.
Thank you, Zippora. Fantastic, fantastic lecture.
And thank you, Miriam, for all your work coordinating this. You've done a great job.
No
Great.
problem. This was really great and smooth this year. Very happy with it.
Very, very good. I'm so happy we could have April speak with her
Me
background
too. That
in
worked out really nicely.
pharmacy.
Yeah. I didn't realize how well Zippora's work tied in with Judy's. So that's very cool.
Yep, I think that's always been a plan when they are doing the the application process or try to make that happen. So
Yeah,
very
definitely.
good. We'll have a very happy